Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. As always, go check out reallifepharmacology.com. Get your free 31-page PDF on the top 200 drugs. Great little resource for you, absolutely free. Just going to cost you an email, and we give you updates as well when we have new podcast episodes too. So go check that out. No brainer to snag that at reallifepharmacology.com. With that, let's get into the drug of the day today, and this is by request from an email I received, and it's Vortioxetine. The brand name of this medication is Trintellix, and this medication as a general class is considered an antidepressant, and that's pretty much in clinical practice the only thing I've ever seen it used for. And probably more specifically, it's really historically been reserved for failure of more traditional antidepressants, such as the commonly used generic SSRIs. So your citaloprams and Zolofts and things of that nature. So that's probably where you're going to see it, as patients who failed numerous other antidepressants, and probably the biggest reason why that's the case, at least at the time of this podcast. This medication is a brand name medication, and so it's definitely expensive, and or you have to jump through insurance coverage hurdles in many situations as well. So that's why its use is probably more limited, and if you're a practicing clinician, probably why you haven't seen it a ton. So with that said, I definitely have seen it used in clinical practice, usually by psychiatry, and this medication does have kind of traditional SSRI activity. With that said, it's also got some other activity on other serotonin receptors. And the challenge with this, and to know exactly how it all plays out, is a lot of this is dose dependent, and the affinity to all these different serotonin receptors varies. And so depending upon the dose that we're using, the actions could vary and that sort of thing, which makes kind of the mechanism of action and how it all plays out really hard to kind of interpret. And then, of course, you factor in pharmacokinetic parameters as well, and maybe pharmacogeneric variations, and you understand why it's difficult to say exactly how it's going to work in each individual person. But the primary mechanism of action is that SSRI type activity, essentially increasing the activity of serotonin. Other notable receptors, so serotonin 5-HT1A, it is a receptor agonist at that receptor, I should say. 5-HT3, it is a receptor antagonist, and again, how that all plays out and how significant that is really isn't spelled out in the literature, at least in my opinion. So dosing of this medication, 5 to 20 milligrams is the usual dose range. Most clinicians are going to start in the 5 to 10 milligram range, maybe 5 milligrams if they're a little bit older, just want to make sure they tolerate it okay. Some might feel comfortable starting with 10 milligrams, maybe in younger patients, things of that nature. And most clinicians are going to increase probably by 5 milligrams when they do increase, maybe after 1 to 4 weeks, just depending upon how it's going and how aggressive the clinician wants to get. All right, so there is some other evidence in addition to the antidepressant effects. So this is, again, specific for patients with depression. So those patients that have depression and they really struggle with some cognitive impairment, some cloudiness in their thinking when they get depressed, Vortioxetine does maybe have some potential benefits in the literature that shows that and may help that. So that's maybe a subset of depressed patients where maybe Vortioxetine is a little bit better than some other traditional antidepressant agents. So that is a subset that you might see this medication selected for. Let's get into adverse drug reactions. So first and foremost, there is that boxed warning, increased suicidal thoughts and behaviors, particularly in kids and young adults, upon using the medication in the short term anyway. So important to note that you're going to likely get that question from patients, so just be aware of that and be able to tackle that question for your patients. The most common adverse effect is going to be nausea. Approximately a quarter of people may experience some nausea. Generally, it's going to be a dose-dependent effect, so if you get more aggressive with starting doses, you probably are going to be more likely to run into that adverse effect. So definitely be aware of that and avoid the prescribing cascade, where we add anti-nausea medications shortly after we've started a drug like vortioxetine that has a relatively high incidence of nausea. So pay attention to that. Less common, sexual dysfunction certainly has been reported, and that's very common with SSRIs as well. Hyponatremia, rare adverse effect, but low sodium levels can result. At-risk patients are probably going to be ones that you pay more attention to. So, patients who've had a history of hyponatremia, they maybe are taking diuretics like furosemide, for example. Older patients are probably going to be more susceptible to this risk as well. Serotonin syndrome. I won't go into that too much. I've talked about that extensively in previous podcast episodes on other SSRIs. And then whenever you use an antidepressant or a drug that works on the brain, in the brain, you always got to anticipate that central nervous system changes are possible, whether it's dizziness or sedation or behavioral changes. You always got to pay attention to that and make sure we're monitoring our patients closely, particularly when starting a new medication or increasing dose there. And then lastly, I did want to mention the bleeding risk. That comes up. I've definitely been asked that by patients and by other healthcare professionals. It's not something I worry about tremendously with drugs that have SSRI-type activity. With that said, it certainly has been reported in literature that there might be a little bit of an increased risk of bleeding there. So I think paying attention to it, if a patient's reporting, abnormal bruising, bleeding, anything like that, certainly vortioxetine's got to be on your list of drugs to at least assess and pay attention to. Most often I've found that, when somebody reports bruising, bleeding, they're already taking aspirin or they're on an anticoagulant or, maybe some high NSAIDs for pain. So patients that generally report bleeding are going to likely have other risk factors as well. But again, I just wanted to make sure to address that because it certainly is in the literature and it is a question that I've been asked about as well. All right, so I wanted to talk about benefits here quick. So just like SSRIs, the benefit for antidepressant activity is going to take a little while. So the challenge with that is you often run into adverse effects right away. So let's take nausea, for example. If a patient runs into that with vortioxetine, they're going to experience that nausea pretty quickly. Within the first couple of days, likely, they're going to experience those adverse effects. Now, with that, the benefits are going to generally be at least 1 to 2 weeks out, maybe even up to 4 to 6 weeks, kind of for that full maximal benefit. So that's definitely a patient education point that you want to drill home. Like, hey, you might not notice feeling any better right away. It may take a little bit of time to begin working and helping depression symptoms, and also educate them that unfortunately side effects may show up initially. So that's always kind of a clinical judgment, risk versus benefit type of thing, based upon how severe the initial adverse effects are compared to, are we going to wait for that potential benefit and to see maybe that nausea does subside a little bit over time. So again, going to have to judge that based upon the severity of those adverse effects. So again, that onset of action for the antidepressant activity, 1 to 2 weeks, kind of for that full effect, 4 to maybe up to 8 to 12 weeks is going to be kind of an adequate trial to see if we're doing anything and helping our patients. Half-life of this medication is 66 hours. So that is definitely helpful when it comes to tapering off and discontinuing. Just like other drugs with SSRI activity, we can have that discontinuation syndrome, and I've talked about that previously and what some of the signs and symptoms are there. But patients can just not feel very good if they stop taking their SSRI medications and they've been on it for a while. So with that said, if we're tapering off vortioxetine, that half-life of 66 hours is definitely helpful in that it's kind of a self-tapering a little bit. So I generally would never recommend if stopping cold turkey. That's not some, unless obviously there's a severe adverse effect or something. Obviously, then we're going to stop the medication. You're going to probably want to taper this over 1 to 2 to 4 weeks at least. But that longer half-life will help kind of ease that cushion or cushion that reduction, I should say, and hopefully we've got a lower incidence of that discontinuation syndrome. From a metabolism standpoint, CYP2D6 is probably the primary pathway, and I'll talk a little bit more about that in drug interactions. If you're in the market for any pharmacist board certification study material like NAPLEX, BCPS, ambulatory care, geriatrics, BCMTMS, or others, go check out meded101.com/store, S-T-O-R-E. We've got a great list of resources there. Definitely go take advantage of them. Help support this podcast as well. If you're a nurse, med student, PA, nurse practitioner, recently released, at least in the United States, Flippin' Pharmacology flashcards. Great resource for anyone going through school, pharmacology classes. Absolutely go take advantage of that, and you can find that on Amazon. All right, wrapping up with drug interactions. So I mentioned CYP2D6, that vortioxetine is broken down significantly by that enzyme. It also is affected or broken down partially by some other CYP enzymes too, but CYP2D6 is probably the major one there that you're going to worry about. So kind of a classic CYP2D6 inhibitor is another antidepressant like bupropion. So if we have bupropion on board, we start vortioxetine. The patient's likely to get higher concentrations of vortioxetine, which is probably more likely that you're going to encounter adverse effects more quickly. So, paying attention to those drug interactions, running drug interaction checker, definitely a good idea whenever we're starting a new medication, and particularly one that's not used incredibly often or maybe you're not that familiar with, like vortioxetine. Bleed risk, so I discussed that a little bit. Basically, I'm going to look out for other drugs that can increase that bleed risk, whether it's anticoagulants like heparin or apixaban or warfarin, or antiplatelet agents, clopidogrel, aspirin, and so on and so forth. So they can certainly have an additive effect onto vortioxetine. And then, of course, serotonin drugs, so drugs that basically have serotonin agonist activity or enhance serotonin activity. So certainly other antidepressants are going to fall in this category. Ondansetron, tramadol is another good example that has some serotonergic activity. Total contraindications, linazolid and other drugs with MAOI type activity. We're going to want to avoid use together there, so that's an important one as well. Otherwise, we increase the risk of serotonin syndrome. And then the last, I will mention CYP enzyme inducers, so classic examples, carbamazepine, phenytoin. They may induce metabolism of vortioxetine and increase the risk for treatment failure, so lower concentrations of vortioxetine. All right, well, I think that wraps up the podcast for today. Hopefully you found some good practice pearls out of this podcast episode. Do me a huge favor, leave a rating, review on iTunes or wherever you're listening. Share us with friends, colleagues, classmates, anybody who could benefit from some pharmacology education. I appreciate you for doing that. If you have suggestions, comments, questions about study materials, the podcast, anything like that, definitely reach out to me, mededucation101@gmail.com, or you can track me down on LinkedIn as well, Eric Christensen, PharmD, BCPS, BCGP. Thank you so much for listening, and I hope you have a great rest of your day.